I am Dr. Jitender Mokta. I am professor in the Department of Internal Medicine, Indira Gandhi Medical College, Shimla. First of all, I will talk about the diabetes. As we know, diabetes is spreading very rapidly in India, and how it differs from the Western is that it is diagnosed a decade earlier. Having said that, what I mean, if it is diagnosed at the age of 65, at an average of the 65 in the Western country, in India it is diagnosed between 50 and 60, and this 50 and 60 is the most productive life in our country. So it affects the most productive life in our country. And moreover, what we are seeing in daily to daily practice is young individuals are being diagnosed at a very high rate. In my personal study in Indira Gandhi Medical College, near about 30% of the patients are below the age of 50, and they fall in the range of 30 to 50. So this is a big concern. And what is more important, what I have seen is that it is equally prevalent, though it is more prevalent in urban country, urban areas, but because like in Himachal Pradesh, where the 90% of the population lives in the rural areas, so it is spreading very rapidly even in the rural areas also. And what I say most of the time is that the patient came late with complication, and they are not being adequately treated. And the most important what we have seen is that we have a data of 260 patients. They came when they developed the complication, and they are inadequately treated. Either they are on the suboptimal doses of the oral hypoglycemic agent, or they are on the maximum doses, but despite that they are not being controlled, and insulin is not talked about. So today I will talk about on the insulin. We all know the God has given insulin is the greatest gift for the treatment of diabetes the God has given to us, and it is a life saving. It's just like an oxygen for type 1, we all know, and for the pregnant lady who is diabetic also. But my concern is in type 2. It is mostly delayed. What has been seen in different studies, the insulin is delayed for near about 1 decade, that is for 10 years, and A1C remain elevated for more than 9%, and patient develop one or other type of the complication. If we see the Indian data, the patient near about there are 16 to 20 million diabetic patients who are having chronic renal disease, and we know in India only 2% of Indian population they afford for the dialysis and for the transplants. This is a big concern here. So what I have seen in my daily practice, there is a reluctance on the part of the physician and reluctance on the part of the patient to accept the insulin, and this is reluctant on the part of the physician to initiate the insulin at a timely manner. And the most common concern when I came across near about 500 patient type 2 diabetes, it is not hypoglycemia, it is not a weight. The most common misconception in their mind is habituation. What they say is, once I will start the insulin, I have to continue it lifelong, because my grandfather or my mother-in-law or my father-in-law had insulin, and they were taking it for the lifelong. Why? Because the traditional way of putting the insulin is when they develop one or another type of the complication, like in CKD, like in case of your diabetic foot. So we do not have another concern. We have consumed the maximum, and after that they have to take it, and they have developed one or another type of the complication, and rest of life they have to take. And this has gone into mind deep-rooted concept in the diabetic patient. Once it started, it has to continue. But what we have learned in the time, when we use the insulin at a timely manner, like it has been shown in various studies, once HbA1c goes more than 8.5 and patient is on 2 OHA already, hardly adding the third OHA does not bring down the A1c to the desired level less than 7. It is at that time that one should try to use the insulin, so that the desired A1C of ADA goal less than 7 is achieved. And this, when we talk about the patients, the habituation is in the mind, and the fear of injection is only shown by 1/4 of the patient. 2/3 of the patient have the fear of habituations, and where this hypoglycemia and weight gain is not a concern in that. So what is important is that we have to educate the patient. First we have to know the concern of the patient. We have to tell about it is not a habituating forming drug. We have to use at a timely manner. We will use it for 2 or 3 months. I will take it back. I will put the patient on OHA back. But when we use the timing at appropriate time, like at the time of the diagnosis, or when the OH is failing after 1 year or 2 years. But once we will use it after 10 years, or once patient will develop the one or another type of the complication, we have to use it at a appropriate time. And another aspect is initiation of the insulin at the time of the diagnosis. I have done a study in Indira Gandhi Medical College, Shimla, where I put the patient who has got A1C more than 9 with osmotic symptom, and who has got A1C 10 without osmotic symptom. And I treated the patient with your premixed insulin for 8 weeks, and to my contrary, the A1C is reduced from 11.4% to 7.34% average after 2 months. And what is the most important that I want to convey here, I want to say here, is that after the completion of 3 years, I followed this patient for 3 years, the A1C and 88% at the 2 months achieved A1C less than 7. And I followed the patient for 3 years. At the end of the 3 years, 73% of the patient maintained the A1C less than 7.3 years. So there is a very good, my personal and what you call day-to-day data, or a clinical or daily clinical practice data, the early insulation of the patient only for the short duration, maybe for 4 to 6 weeks, can maintain the glycemic control for the very prolonged period. This is what I want to talk about the diabetes. Second concept is that I want to talk is about your acute coronary syndrome. We see a lot of patients with acute coronary syndrome. I will put the patient at the 3 level. One patient is at a tertiary level. We have got the facility of what I call that is the angioplasty or bypass or angioplasty, and second, or we have got a thrombolysis at that level. And second is a place like your community health center where you got a facility of your thrombolysis, and third is a patient where most of the India resides and where we have got only primary care physician. We do not have these facilities. So I want to say, time is muscle in heart attack. Time is muscle. It is not only this time matters at what level we start the treatment. So first I will go to the first tier system. When the patient is coming at our peripheral level, so the primary care, where we are a primary care physician assisting. A patient is coming with chest pain, and we go for the ECG, and for the ST elevation is there. The first thing they do not have any thrombolysis. We know ST elevation is there. They have come within 120 minutes. They do not have facility. What they have to do is they have to first, don't waste the time. Within half hour of reaching in their institution, what I call as door to referral time, it should be less than 30 minutes. Once they have diagnosed the patient at the peripheral level, within 30 minutes they should try to refer the patient to the capable hospital where either the thrombolysis is available or where the angioplasty is available. And what they can do is what I call a poor man angiography or angioplasty. That is that they should give 300 milligram of the dispersible display. If the primary care physician has done the job, what a cardiologist has done in the form of angioplasty. So first give 300 milligram of the aspirin. Within half an hour, send it to the capable hospitals. Now suppose we have 2 scenarios. The capable hospital is a angioplasty approachable hospital. The patient should be referred within 30 minutes to the angioplasty capable hospital within 30 minutes, and the angioplasty capable hospital should be at a distance less than 120 minutes. Within 2 hours, the patient should reach there so that he may undergo angioplasty procedure when the outcome is the best. Suppose he does not, the place is so far that he can't reach to the angioplasty capable because it's very far and few in, because near about only very few patients, less than 10% they are capable hospital in India, and we know only 42% of India ST elevated patient get this thrombolysis, and only 21% is the appropriate thrombolysis, we can call it the right way of doing the thrombolysis. So second time, if angioplasty capable hospital is far off, patient can't reach 120 minutes, we should try to send the patient to the thrombolysis capable hospital, and that we should try to send the patient reach there within 90 minutes, so that the this door to needle time there should be less than. Once he or she reaches in the thrombolysis capable hospital, the doctor there should keep a very important time, that door to needle time, that is reaching in the hospital, crossing the door of this and putting the needle inside, should be less than what you call less than 90 minutes, and start the thrombolysis should be less than 90 minutes. So the two important aspects. First, at the primary care hospital, they should give the aspirin without wasting time, and within 30 minutes he should refer, and the referral time should be less than 30 minutes, and the reaching time should be less than 90 minutes. Once he reached the thrombolysis capable hospital, within 90 minutes, the doctor sitting should start the thrombolysis, what I call a door to needle time. Now patient is referred from your from some place, what you call angioplasty capable hospital. That again he should be referred within 30 minutes. This time interval is important, and he should reach the angioplasty capable hospital within 2 hours. And once he reach the angioplasty capable hospital, there the door to balloon time should be less than 90 minutes. The time is muscle here. The time is muscle. Why? Suppose we waste the time and we do not give the thrombolysis, or we give the thrombolysis and we do not give it timely. It may save the patient, but the muscle is damaged. So after some time the patient may come back after 6 months, 1 year with your cardiomyopathies. So we save the patient, but we have the patient is coming with your what you call left ventricular dysfunction, or what I call the cardiomyopathies. Now second aspect is, if we have got a facility for angioplasty capable hospital and we have got a facility for your thrombolysis, the preference should be given for angioplasty capable hospital. Reason being, when we compare plasty versus a thrombolysis, we only open 10 to 20% of the thrombus with your thrombolysis, and less the 90% remain there. And second, the flow, what we measure is the flow is only restored only in case of your thrombolysis 60%, where the flow, the TIMI3 flow is restored near about more than 90% in case of angioplasty, and we open near about the 90% of the thrombus is opened. So preferably, compared to say 60% of the TIMI score to 98%, and comparing on 10% opening the thrombus and more than 90% opening the thrombus, the preference should go for your angioplasty capable hospitals, and that is the second concern.